Okay. Okay. So, good evening and welcome to lecture series once again. And today I thought because we have taken a lot of drugs and that is becoming now monotonous also. So that is why I gave you polls today on excessive crying. Of course, I have shared the link. Few of you might have seen it, but let us try to take it up again in the form of a case scenario. And I will not try to use the PPT, so you can switch on your videos. It will be better if at least three, four faces are there in the recording. So what we can do is we start with an exercise. Suppose a 9-month-old child who is accepting feeds and playing normally in the daytime and start crying towards evening, and the cry becomes persistent and it is constant, right? So, and the child is crying, crying, and crying. And now the parents, they have to go to a doctor, right? It could be your own child also. It could be a child, infant in your family also, because this is a very, very common situation uh, which you will have to face, right? And now the child has been brought to you, and how you are going to do. Suppose you are sitting at your urban health center, or maybe at rural health center, or maybe at your home, or your neighbor brings the child to you and the child is crying. So how you are going to proceed further, right? That is important to understand. So how you are going to take the history, and what are the things which you are going to ask in the history, and then what are the things which you are going to examine and how you are going to examine the child. So this you will have to understand first, and that is why I put the poll. And in the beginning, I will tell you theoretical aspect. The theoretical aspect is this, that crying is a normal phenomena, but excessive crying is not a normal phenomena. So we have to level what is excessive crying first. So if you have seen the lecture, then yes, I put it in the poll also, that if a child cries for 30 minutes or for 1 hour or for 2 hours or for 3 hours in 24 hours, where you will label it as an excessive crying. So what is your answer? So you have put the answer in the poll. The correct answer is that if it is more than 3 hours. And when we say it is more than 3 hours, it does not mean that it has to be continuously 3 hours. It means that cumulative in 24 hours, if the infant is crying for more than 3 hours in 24 hours, then we label it as excessive crying. So videographic studies have been carried out, and what they found that infant normally they cry more towards evening, right? Normally they cry more towards evening. So this problem will usually start in the evening and can persist throughout night also if no remedial action is taken. We have seen number of cases in the middle of night of laymen's, even of doctor's kid we have seen, because nobody can tolerate the crying of a young child for more than 10 to 15 minutes, right? So first of all becomes your history, which is very, very important. So first of all, you'll have to take the history in detail, right? And in that, first of all, you will have to ask what happened to the child, whether the child was normally normal, whether there is any other associated symptom. Like, what is the uh, consciousness level of the child? If there is any history of convulsion, if there is any history of fever, if there is any history of vomiting, if there is any history of loose motion, if there is any history of eye discharge, let us start from top. So, if there is any history of high grade fever, unconsciousness, convulsion, or if there is history of any eye discharge, or if there is a history of any ear discharge, or if there is a history of any nasal blockage, if there is a history of a sound which is coming from the throat in the form of a stridor, if there is a respiratory difficulty or not, right? Then, if there is a protrusion in the abdomen or not, or if there is a history of fall or not, if there is a history of handling of this young child by another elder child, right? So these are all the things which are very, very important to ask in the history first. And if the answer of all these questions is no, right? If the answers of all these questions is no, that means uh, that there are less chances. Now you have taken the history. Similarly, you will have to examine the child. So again, it is important because from next time onwards, we will be taking more lectures on assessment and other things. So you will have to examine the child, and in basic medicine, there is a one fundamental that you'll have to remember. If you do not know about the problem, but you know the anatomy of the body, so you start from top, come to bottom, start from outside, go to inside. That way, you are not going to miss anything. So that is why I said I am not going to use any PPT on this. I will be talking about like that, and that is how I have enumerated all the points in the history also. Similarly, in the examination, because it is a 9-month-old child, right? So where will you examine this child? That is the first question number one. Will you put the child on the couch, examination couch, or will you examine this child in the lap of the mother? Where? What will be your preference? What is your answer? Anyone?
Lap of the mother.
Lap of the mother. Absolutely correct. So, because a 9-month-old child is afraid of stranger or lying alone, and you will have to examine also in greater detail. So, you have to examine this child in the lap of the mother. Now, so that way the child will be in the erect posture also, not in the supine posture. It should be in the lap of the mother. The child will be erect. So first of all, you will look for anterior front nail from top. First of all, you will look for anterior front nail. Of course, anterior front nail closes by between 12 months to 18 months. So at 9 months of age, it will be open. So what you are supposed to do is you have to look for bulging of the anterior front nail, and you have to look for pulsations. In history, you have taken there is no fever, nothing is there, right? But you will have to still examine the child, and you will have to check the temperature. And nowadays, there are so many devices are available. Even the remote sensors temperature devices are also available by which you can check the temperature. And you will look for the anterior front nail, whether it is normal or whether it is bulging. And the best position is again a erect position in the lap of the mother, because if you put the child on the couch, there will be fullness of the anterior fondant, which can misguide you, right? So that is that you will have to check, and if that is normal, then you will come down to the eyes. You will look into the eyes if there is any redness in the eyes or there is any discharge in the eyes. Especially, you will look in the inner canthus of the eyes, and you can press there also below the eyes to look whether any pus is coming or a discharge is coming from there or not, right? So, or the eyes are full of pus material or not. If that is normal, then you are going to look into the ear of the child, and you are going to look for any serous or serosanguinous discharge which is there or not. This you can do with the help of a torch. Again, it will be better to examine the child in the lap of the mother. And when the child is in the lap of the mother, you will have to ask the mother to hold the child with both the hands, with one hand like this, you will cover both the hand of the child and you will hold the head with the right hand, because after ear you are going to put spatula into the throat of the child, and that is the best way. When you have holded the child in your lap, and the mother is holding the child in the lap, and then with the other hand holding the head, so that you can easily put the spatula in the mouth of the child, and with the help of a torch you are going to look into the throat. You are going to look for any pharyngitis, tonsillitis, epiglottitis, etc., and you are going to look for secretions. Similarly, you will try to look into the nose also, whether there is any purulent discharge from the nose or not, right? So that is important, because all these conditions, like if I start from the top, we have ruled out meningitis and encephalitis when we say the consciousness is normal, there is no fever, there is no bulging of the AF, right? And there is no history of convulsion. So you have ruled out that part. Then you can do look for the neck rigidity also. So how do you look for neck rigidity in a small child, 9 months of age? Even if you do
Try to
not know,
move the neck.
no, no, you have to put the child on the couch, and you have to put the head and at the extreme end of the bed, so that the head is going to fall a bit with the help of gravity. If you do that by this mechanism, you will be able to remove the voluntary rigidity which will be there. If you try to push the head of the child from back, he will resist otherwise, right? So that you'll have to examine the child in a lying posture. Absolutely, the head should be on the edge of the couch. Examination couch should be coming a bit uh, behind the couch, so that you can lift the head and look for the neck rigidity. So that way you will be able to rule out meningitis, you will be able to rule out conjunctivitis, you will be able to rule out otitis media, you will be able to rule out throat infection, you will be able to rule out croup also, and you can listen for stridor also. If there is a stridor, that could be a croup syndrome. Then you will go down, and examine the chest. For that, you'll have to count the respiratory rate. And if the child is, say, 9 months of age, what is the normal respiratory rate at this age group?
30.
Hmm?
uh, More than 24.
No, no, no. That is for adults. That's not for children.
More than, I guess, 40, or between.
Yes. Yeah. So you will have to count the respiratory rate for full 1 minute. For full 1 minute. Right? That is another tip which you'll have to do. And then you are going to auscultate, you are going to listen for any accompanying sounds, whether there are gaps or whether there are onkai. If the respiratory rate is normal, you are also going to look for the chest indrawing, right? Uh, Whether the chest indrawing is there or not. If everything is normal, then means you have been able to rule out the pneumonia part also. There is no pneumonia, respiratory rate is less than 40, and there are no chest indrawing, right? So that way you have been able to rule out pneumonia. Now you have to look for heart rate also. That is again important to understand, because there are cases where arrhythmia could present, and especially the PAT, paroxysmal atrial tachycardia, could be there. So we have seen number of cases like this where you have to just listen to the heartbeat, count it, and if you are not able to count it, if it is, say, way beyond 100 or 150 or 160, then probably you are dealing with a case of what we call it, PAT, right? So then you will have to advise, refer the child for an ECG or echo, so that too you can find out whether there is any arrhythmia, because arrhythmia, this kind of arrhythmia can also lead to excessive crying, right? Then, if the heart rate is also normal, respiratory rate is normal, there are no chest indrawing, so you have ruled out major problems. Now you will go to the abdomen, and in abdomen you are going to look for what? Hernias. You are going to look for umbilical hernia. You are going to look for inguinal hernia, because excessive crying could be there because of the strangulation of hernia, right? That is again important. So you'll have to examine the abdomen. You are going to examine the hepatosplenomegaly. But remember, in children, one finger hepatomegaly below subcostal margin up to the age of 5 years is considered normal. One finger below the age of below the subcostal margin, hepatic enlargement is considered normal, right? That is important thing to remember what is normal. So you are going to look for umbilical hernia, you are going to look for inguinal hernia. If there is no evidence, then you will go further down, and then you have to look for torsion of testis, testicular torsion, because that's a very painful phenomena, and it can also give rise to excessive crying, excessive crying, right? So that is again very, very important to check all these things. Then, if nothing is there, right now, and child is still crying, and then you have to examine the limbs. And in limbs, there are two important things. So you'll have to examine the upper limb, and you have to do the pronation and supination. Pronation of supination of the arm in the child. You have to do that. Why I am saying so? Because we have seen number of times what usually happens is, if there are other elder children in the family and there is a small child, the elder child usually hold the hand of the younger child and pull it, and this result in a pulled elbow. This result in a pulled elbow. And when this phenomena happens, then the pronation and supination is not possible. It is a painful phenomena. So we have seen, and I still remember a case, rather two, three cases, where I was called by one of my friend from another city, and that his nephew is crying for 2 days, and he has been to every pediatrician, and they are not able to find out the cause, right? So I just asked him to do pronation and supination, and he said he is not able to do it. When you take the child to an orthopedic surgeon, and he will maneuver it, and your child will be normal. And that came out to be the absolute correct diagnosis. And within 5 minutes, the crying child stopped crying. So that is important to understand. And then in the lower limb, if the child is lying in the bed and crying, and uh, mother is has taken the child in the lap, and the complaint is like this, that whenever they try to lift the child from the bed, the child start crying. So there is another condition, of course, which is a which uncommon condition, but it is a condition which is known as pseudo paralysis of lower limbs, which is a feature of vitamin C deficiency, which is a feature of vitamin C deficiency. And this usually happens in some children, and this is usually because of the subperiosteal hemorrhage, which happens in the lower limb. So as soon as you try to lift the child starts crying. So this is the examination you will have to carry out. Then, besides that, there could be physiological causes of crying, like if the child is, depending upon the age, because at this age, uh, the thermoregulation is developed. So it will not be that if the child is kept in a cold temperature, then he will get cold and start crying, because the thermoregulation comes by the end of 1 month. Thermoregulation is well established by the end of 1 month. That you'll have to remember. During the neonatal period, if you put the child in excessive heat or excessive cold condition, then he'll start crying. If the child is wet, then he'll cry. If the child is hungry, then he'll cry. If there is excessive noise, then he'll cry. And if there are strangers, then he will also cry. So these are few physiological causes of crying. Rest pathological causes we have discussed from top to bottom. Top to bottom we have discussed. Almost everything is covered. So if you are not able to find out anything, neither anything in the history nor anything in the examination, then we say that this child is having colic, right? Normally, when we say colic, you think that we are talking of either abdominal colic or biliary colic or ureteric colic, right? But here, colic is an acronym. Colic is an acronym, and whatsoever I'm teaching you, it's based on the series of PCNA, that is Pediatrics Clinic of North America. It is not given in any even textbook of pediatrics, right? So there they have labeled colic as an acronym, and the full form of colic is cause obscure lengthy infant crying. Which one of you have correctly written in the WhatsApp group also? So if the child is crying excessively and you are not able to find out any physiological or pathological cause, then we say that the child is having colic, and it is very common. Now, it's not only important to know what the problem is there, but then you'll have to manage that problem. When we talk of management of colic, then there are two possibilities. There are two modalities of treatment. One is a behavioral therapy or non-pharmacological therapy, and another one is a pharmacological therapy. Non-pharmacological therapy is a behavioral therapy. We just ask the parents to put the child on a two-wheeler or in a four-wheeler or whatsoever conveyance they have, right? Remove the child from the environment, take him out for half an hour, and child will stop crying. And this I can share with you right now here, that we had sleepless nights due to this particular phenomena where our juniors, our colleagues, their children or their grandchildren used to cry in the middle of the night, and then they all used to bring the child to us, and then we have to wake up in the middle of the night. And suppose if they are coming from a distant distance, say half an hour distance. So what usually used to happen was that we used to take the child and put the child on our examination couch, and child stops crying, and everybody is then in a fix key what has happened. Rather, some time or some of the time they used to feel embarrassed that the child was crying and now he's not crying here. So that is a behavioral therapy, because you have changed the environment of the child. You took the child from the same environment and you take him for a ride. It is a ride for a child, right? For half an hour or so, and then the child is fine. If that does not work, then you have to go for a pharmacological treatment. Pharmacological treatment. And in pharmacological treatment, there are two drugs which are to be used. One is antispasmodic drug, which is known as dicyclomine. So whenever you are going to start the pharmacological treatment, remember you have to give this treatment minimum for 3 days. It is not that you are going to give a single dose. So you will have to use dicyclomine hydrochloride, right? And you have to give 5 milligram, 5 to 10 milligram of this drug 3 times daily for 3 days. 3 times daily for 3 days. If the child does not respond even to this, then you will have to use phenobarbital. Phenobarbital. Of course, now it has become a Schedule H drug. So until and unless you write it on a prescription and stamped it, the parents will not get the drug. But if you are going to write the phenobarbital, so you must know the dose. So the dose of phenobarbital is 3 to or 5 to 8 milligram per kg per day. 5 to 8 milligram per kg per day. By this dose, you'll have to say. So suppose if it is a 9-month-old child and his weight is 8 kilogram, so you will have to give him maximum by 8 milligram if you give. So then you have to give him 64 milligram. So normally phenobarbital suspension is available, right? And the 5 ml might contain 20 milligram, something like that, or 4 ml might contain 20 milligram, depending upon the type of preparation which is available. So you will have to give accordingly. And whenever you will
So,
give
sir, I missed
phenobarbital,
why we are giving phenobarbital at the first place.
yeah, pardon?
Sir, why we are giving phenobarbital? Uh, I missed last. few seconds.
Okay. Okay. You, first of all, you will have to go for a non-pharmacological treatment. If that non-pharmacological treatment fails, then you will give dicyclomine. Then you will give dicyclomine, right? And dicyclomine dose is variable in children from 5 to 10 milligram, and it is to be given in TDS dose, right? 5 milligram TDS. And whenever you are going to start it, you'll have to give it for 3 days. Suppose you have
Okay.
given this and the child is still crying, is not responding, then you are going to add phenobarbital. Then you are going to add phenobarbital. Or if it is the
Okay.
middle of night, right? Say 1 a.m. somebody comes to you, then you cannot experiment because you say you give dicyclomine and then the child does not respond. Then he'll come back to you again at 3. So you write both the drugs, dicyclomine as well as phenobarbital, right? So
Noted.
phenobarbital, whenever you write, remember, whenever you write phenobarbital, you will have to tell the parents in clear words that your child is not having epilepsy, and this is not, I have not prescribed it for epilepsy. Otherwise, what will happen? He'll go to a medical store, and medical store person will always say, "Oh, your child has got epilepsy, and that is why it has been written." Then he'll come back again to you and will disturb your sleep. So you have to be very, very careful whenever you are going to write. The two precautions you'll have to take. It is now become a Schedule H drug. You have to write it on a prescription. You have to stamp it. And you have to tell the parents that this is not for convulsions. If the child does not stop crying after taking dicyclomine, wait for half an hour or so, still the child is crying, then you'll have to give phenobarbital also. So that parents can also sleep and you can also sleep, right? And again, whenever you prescribe this phenobarbital along with dicyclomine, everything has to be given. Everything has to be given for 3 days. For 3 days, and there are certain kids, there are certain children who will keep on having this problem every week or every 15 days or every month. They will have this crying episode, and majority of time they will start late in the evening, and majority of time if the parents are not very conscious of the fact that it will keep on increasing, then they will keep on troubling you in the middle of night. So that is important to understand. So I just wanted to teach all this to you without the help of any PPT because I just wanted to emphasize one point. That point is that whenever you take history in detail, start from top, come to the bottom. Similarly, when you do the examination, start from top, come to the bottom. Start from outside, go to inside. That way, you are not going to miss anything, right? Chances of missing anything will be difficult, will be absolutely eliminated if you follow this approach. And this approach is not to be used only in a crying child. In every child, whenever you are going to examine a child, you should follow this approach so that you are not going to miss anything as far as the history taking and examination is concerned, right? So that is why I have not used any PPT today, just to see how much I remember and how much I can teach you and how much you can understand it in this manner. So you will have to follow this approach for examination as well as for history taking so that you will always be able to reach to a definite right diagnosis because you are not going to miss anything, right? So that is what I wanted to teach you today. If there are any questions, you are welcome, right? I will try to put the PDF of this uh, presentation if I get. Of course, I shared the link where the PPT is also there. I have taught it with the help of PPT, but today I have taught you without the help of a PPT. If you wish, I can rapidly go through the PPT. If you wish, I will. Otherwise, we can stop it here because it is half an hour or so.
So
If you
there's
wish.
one question.
Yeah.
So why majority of children have this excessive crying in evening or late evenings?
So that is the observed fact. So that's a very good question you have asked. This is an observed fact. In US, they did a videographic studies, right? They put the children under the videographic surveillance, and they then averaged out, and they found out that majority of time the child, they cry more towards evening. They cry more. It's an observed fact. There is no physiological or pathological reason behind.
Yes, so yeah, because mostly this thing happening in starting 1 month, and because of
Mhm,
this factor only, the mother diet is also changed as
mhm,
per like traditional things.
mhm.
ये नहीं खाना चाहिए, ये नहीं खाना चाहिए. That's why like
No, no,
whenever
no.
the
Yes,
patient,
yeah. There are a lot of restrictions and there are a lot of things like there are so many guttis which are given. I have never used guttis in my 40 years of my practice.
so still in the rural areas, the that gutti
Mm.
is giving to the child.
Yeah, but it should not be given. It should not be given. That is what is the science is. You see, science says you have to follow the evidence-based phenomena only, right? And what is the science says? Majority of time they unknowingly what they do is when the child start crying, they take the child and go outside house. So
Mm,
that's the kind of a behavioral therapy. It is not the gutti which is working, it is the
mm,
behavioral therapy which is working basically.
okay.
So but then there should not be any restriction on the eating of the mother, that okay, don't eat this will cause a lot of gas in you and a lot of gas in the child. No, nothing to do with that, nothing to do with
Yeah,
that.
because sir, in a government OPDs, we hardly get that much time to counsel the patient because even not about the illiterates, even the educated people are coming to the OPD and they're like, the mostly the mothers complain ki because of this factor only our diets are so much restricted that we are having only some of females complain ki we are giving only milk because of this factor because the baby is frequently having the excessive crying spells.
Yeah. So that is why it is important to understand that the nutrition of the mother is already compromised in lactation,
Compromise.
right? And then because of this phenomena of crying, it is further compromised. So it should not happen that way, and that is why it is important to understand. And this colic phenomena is very unique, and you can explain it, of course. Counseling needs time, that I agree with you, and you don't have time. But then, first of all, you should be confident about it, what you are going to tell. If you are confident that you are correct, then maybe in 2, 3 minutes, you will be able to provide the adequate knowledge. And you can tell them at least modalities of the treatment can be explained, that, okay, you can take the child change the environment of the child, and these are the drugs which you can use. And there is no point in uh, avoiding certain foods or food items basically. So that is to be explained to mother-in-law and sister-in-law, especially in our cultural setups. That is important, right? So they will say, and we have seen this. You see, this problem we have seen number of times. Majority of time, the mother-in-law will say, "अरे डॉक्टर को क्या पता, बच्चे तो हमने पाले हैं, है ना?"
Yes, sir. Yeah,
This is the complaint. डॉक्टर को
most
क्या पता,
common.
बच्चे तो हमने पाले हैं. So
Hmm.
then you'll have to tell कि भाई आपकी मदर इन लॉ ने 1, 2, 4, 5 बच्चे पाले होंगे, हम तो सौ बच्चे पालते हैं. So
Hmm.
we take care of hundred and thousand of children. So what we are saying is more correct. That is not correct. These are the practices which are to be stopped basically. Why do you compromise? So much of anemia is already there in our
Hmm.
country, and the lack of nutrition is also there in the lactation period. So much of malnutrition is there in our country, right?
Yes, sir.
33%, 34%, 35%. So if the mother is not going to eat good quality food, then the lactation is going to be affected. The quality of milk is going to be affected, and so on. So many things will happen, right? So
Yes, sir.
again, that is important. So that is why I thought let me repeat this lecture for you in a different manner, not with the help of a PPT, so that you will appreciate that yes, you can
Yeah, definitely,
uh,
sir. It's a very good lecture.
uh, from top to bottom approach. You are going to cover everything and you are not going to miss anything. So that way you will become clinically much more perfect and sound in your practice. That is what is important to understand. You don't have to mug up anything. You just have to remember the body parts and then move forward.
Yes. Thank you,
So that
sir.
is it. So,
Sir,
okay.
good evening,
Yes.
sir.
Good evening.
Sir, nowadays season of swine flu is there, so are children or मतलब, are children prone to risk? मतलब normal cold is so common. So should we worry about
Yes.
swine flu and all? मतलब common cold is
So, listen, there is a difference between common cold. Common cold usually is what is happening is uh, it's only running of nose or blockage of nose. Swine flu is characterized by high grade fever and cough. And this fever will not come down even with the help of antibiotics, right? It will never
right.
touch normal. It will never touch normal also. So that you'll have to understand. And then maybe you need to give Tamiflu type of phenomena, uh, type of drugs. So, but that for that you'll have to do the investigation and confirm the diagnosis.
So for
So,
now, yeah.
yeah, for now you cannot treat Tamiflu like any other common cold condition. Common cold is where you are having either running of nose or there is some blockage in the nose and there is no fever. In
It's no,
swine
it's
flu, the
low grade fever.
fever is high grade, high grade. Suddenly it will come, it will go to 104, 105, 103. Such a high grade fever is there. We are seeing a lot of cases. So, of course, it has its own duration. It is not very fatal in young children. Otherwise, you can take this tetravalent vaccine, but the vaccine problem is this that depending upon the guidelines from the WHO and CDC, you will have to understand which strain has to be used, and the vaccine has to be used every year. The vaccine has to be used every year. It is
So
not
in this
that
case,
you use it for 1 year and then next year you will be protected. No, every year. It is recommended, vaccine is specially recommended, right, for the elderly age group above
right.
60 and people who are having comorbidities, they must take the vaccine every year. But if you start the vaccine right from infancy, then you can imagine you'll have to give 70 shots or 80 shots depending upon the age. Every year you'll have to give. You can't say that you will give it for 1 year and then will not give it. Once you start giving it, then you'll have to give it every year. So that
So
is
we should
the
know.
drawback of the vaccine, right? And
So
you will have to look into the efficacy also. So that is again important. So vulnerable population is elderly, where you'll have to with comorbidities, where you'll have to use this vaccine
so
every year.
for the
At least, suppose if I start taking at my age is now 70, if I start taking now, so maybe another 10, 15 years I have to take. If I live another 10, 15 years,
then you will
then
live
I will
long.
take
Don't worry.
it. Nobody knows, yeah. After COVID, you know what has happened. So many complications and
Matlab,
problems
we
are
wish
there.
that you live long. Matlab, you are
Hmm.
doing so good, so much
Thank
good
you.
for
Thank you.
everybody.
Thank you. Thank you. So, but that is the point. That is why I'm not a proponent of a flu vaccine, basically, because then it has to be used every year, and every year the strain will keep on changing. Like this year, the recommendation is tetravalent. Last year, the recommendation was of trivalent. Because I get it every year. So my time has also come up to take this. In September, I have to take the vaccine. So
So for
that
a
is
20
that.
months, yes, sir, actually for 21 months old baby, so
Hmm.
he has probably low grade fever. Matlab, grandparents didn't document it, but they are saying that the baby maybe 99 fever is there, 99.5. They gave
Hmm.
PCM directly, and the
Hmm.
baby has cold. Earlier, he
Hmm.
was on antibiotics because he had diarrhea. He had UTI, or you can say
Hmm.
rash was there, and
Hmm.
he had fever. Earlier, high grade
Hmm.
fever.
Hmm.
So he was on
So,
antibiotics for 7 days. But
hmm.
now, no prominent symptoms are there except low grade fever, which they are claiming, and
Hmm.
cold is the most prominent symptom, and obviously
So,
watery eyes and cold.
yeah. So you'll have to give him a symptomatic treatment and then try to improve the immunity of the child. That is important, right? Because the diagnosis is not made, and if there was a rash, it could be a viral phenomena, right? Rash is usually Depending upon what was the nature of the rash, you'll have to decide accordingly. But if the fever is persisting, then the chances are this that it could be something else along with the viral infection. It could be
So
something else.
earlier fever was there, then it stopped. Then it
Mm.
stopped. Fever was treated.
Mm.
It's not continuous. It was treated. Then baby was
Mm.
fine for
Then
two three
again, it
days.
has come up. Yeah, it has come up again. So that is what I usually teach and tell, that the viral infections, they decrease the immunity, and then you are more prone to get a secondary bacterial infection again, right? So you'll have to find out the nidus of infection. You'll have to examine the child once again in detail, right? So, and then there must be something, or otherwise, then you can simply go for a CBC, not anything else, and see if there is any evidence of any infection. If there is no evidence of infection, just put him on symptomatic treatment, give him multivitamin, get his hemoglobin done, hemoglobin and general blood pressure, because what you are saying, 19 months, the child
I said
must be anemic. 20, how much?
21 months.
21 months. So if the child has not never been on iron supplementation, he would have become anemic by now. So just tell
And
them to get a hemoglobin, GBP and CBC done. And once you will find anemia, then you have to give good amount of iron doses to the child plus multivitamins, and gradually then he'll cope up. What is the weight of the child? 21 months, if you
weights are
remember.
9.1 kg.
So he is already going into the
Under
process of malnutrition, because 2 years it should be 12 and he is 9.1. Only 2 3 months are there. And in 2 3 months' time, he is not going to gain. Uh, how much he is going to gain? 2 kg in 1 year. So how much? 150 grams. So 450 grams maximum he can gain. So he'll be somewhere 9.5, 9.6, which will be in comparison to 12, will be less than 20%, right? Because 12
right.
ka 10%, around 20%. He'll be coming somewhere 79 to 80% of the expected weight. So he'll be in grade one as far as the old classification is concerned. But for the recent classification, he'll be underweight. So if he is underweight, then he'll be anemic also. Definitely it is going to. So get this done and then you can share the report with me. So I'll advise you further, right?
So
So that way
for
we can do
time being, sir, actually, we have to get him investigated. No? It will take some time.
it.
So for
Hmm.
now, should
For
we
now,
start
you can
separately?
simply put him on an antihistaminic and antipyretic as well as some multivitamin. But
Multivitamins are A to Z. Which multivitamin?
हाँ
A to Z.
A to Z दे सकते हैं. You can, or there is a Riconia by Ranbaxy, comes by the name of Riconia if it is available. If it is not available, then you can use A to Z, right? So, but then the problem is this: if you will give this, then they will not get the hemoglobin done. That is the most important thing which is to be done. So that you should tell that this is important and it is to be done. I am writing this, but I have to adjust the dose as per the reports. If you tell this, then they will probably agree and get it done, right?
Right, sir. So, cetirizine in the dose of 0.2 milligram per kg, right?
किसकी?
Cetirizine, sir, cetirizine is start करना ना?
हाँ, या सेट्रिजिन दे सकते हैं. You can give cetirizine or loratadine, whatever. 0.2 milligrams से दे सकते हैं. Yes, absolutely. Both can be given
Right.
by the.
Both can be given.
Yeah, you have to give 2 milligram maximum, because 9 kg you told me the weight. So it will be 2 milligram, and normally cetirizine syrup contains 5 milligram. Similarly, loratadine also contains 5 milligram. It's original product loratadine is by company, and the trade name is Elaspan. You can use that. You can use that. So you have to give 2 ml only. You have to give 2 ml.
Right, sir. And syrup A to Z for 1 THF, right, sir? 1 tablespoon
Yeah.
limit.
Yes, 5 ml is sufficient. 5 ml is sufficient.
I remember. Right, sir.
Okay.
Thanks a lot, sir.
Okay. Thank you
Thank
so much. And I'm stopping the recording now. Mm.